Hello, my name is Dr. Saquip Mahmood and I'm a GP with special interest in diabetes and cardiovascular diseases. This is a short presentation on CKD. CKD is very common. It is a marker of cardiovascular risk and CV death. Intervention is necessary in order to prevent the progression of chronic kidney disease to end-stage kidney disease. Progression of CKD is non-linear and variable, and end-stage kidney disease requiring renal replacement therapy is extremely uncommon. CKD is defined by presence of reduced eGFR, proteinuria, hematuria, and or structural abnormalities persistent for more than 90 days. Classification of CKD is into 5 stages. Stage 1 CKD is when the eGFR is normal, which is more than 90, with presence of an alternative marker of renal damage such as biopsy-proven glomerulonephritis or presence of reflux nephropathy or adult polycystic kidney disease. Stage 2 CKD is eGFR between 60 to 89 with presence of structural abnormalities. In the common general practice, we would be receiving blood results which would normally be reported from CKD stage 3 and onwards, and therefore these are the patients which we'll be managing most often. So CKD 3A is eGFR from 45 to 59. Stage 3B is eGFR of 30 to 44. Stage 4 CKD is eGFR 15 to 29, and stage 5, which is also called end-stage kidney disease, is eGFR below 15. CKD is very common in type 2 diabetes. Therefore, 40% of patients of CKD would have type 2 diabetes. Next in the list of causes is hypertension. About 27% of patients will have hypertension as an underlying cause of CKD. A small percentage of patients will have glomerulonephritis and interstitial nephritis, and the rest of the causes would be due to outflow tract obstruction or other structural renal abnormalities. It is important to recognize which patients may be at risk of a CKD, and we should actively screen these patients and diagnose CKD and intervene to prevent complications and prevent the progression of kidney disease. So which are those patients? Patients who've got type 2 diabetes, obviously, or patients who are hypertensive, patients who've got heart failure or coronary artery disease, and do not forget those patients who've had one single previous event of acute kidney injury. These patients remain at high risk of developing future chronic kidney disease. Patients who've got structural renal disease, such as presence of renal stones in the males, benign prostatic hyperplasia or reflux nephropathy, remain at risk of developing CKD. Patients who've got multi-system disease such as rheumatoid arthritis, systemic lupus erythematosus, or vasculitis are high risk for CKD. And finally, patients taking nephrotoxic drugs, and the top of the list is non-steroidal anti-inflammatory agents, and these are the patients who are at a high risk of developing CKD. Also, patients who are on lithium or patients taking cyclosporine or mesalazine are the ones who require monitoring in order to diagnose CKD. Monitoring of CKD is very easy. For stage 1 and 2, we require annual UNEs. For stage 3A and 3B, it's 6-monthly UNE monitoring. Stage 4 CKD require 3-monthly UNEs, and stage 5 require 6-weekly UNE monitoring. Management of CKD is very easy. Essentially, we monitor the renal function and assess the rate of change in renal function. It is essential to have a very good blood pressure control with best practice guidelines blood pressure target of less than 130 over 80 or even lower in patients with two or more comorbidities such as presence of diabetes and hypertension and ischemic heart disease. The treatment of choice is preferential use of ACE inhibitors or ARB to prevent or halt the progression of kidney disease. I cannot emphasize enough the importance of good glycemic control for patients who've got diabetes with CKD with preferential use of newer agents such as GLP-1 receptor agonists, DPP-4 inhibitors, and the SGLT2 inhibitors. There is a newly emerging evidence-based study such as Credence study, which essentially has found that giving patients with CKD SGLT2 inhibitor delays the progression of kidney disease and prevents CV death. However, in the UK, currently this is not a licensed use and the license is soon to come, and then we will be able to initiate SGLT2 inhibitors routinely on CKD patients. Smoking cessation as of any cardiovascular disease remains essential. Smoking would cause rise in blood pressure and affect renal blood flow and affect renal vasculature. Therefore, essential to stop the patients or give smoking cessation advice. Dietary advice requires patients to consider avoiding high potassium diets to maintain a good fluid intake and where necessary referral to renal dietitians. Finally, do not forget to reduce the cardiovascular risk as most of the CKD patients have got very high risk of developing cardiovascular events and therefore offer them aspirin and statins. Complications of CKD are mostly seen at the later stage of chronic kidney disease such as stage 4 and onwards. So therefore the commonly seen complication with CKD4 is renal anemia. We often also come across CKD bone disease, and hyperkalemia is also common in these patients, particularly those treated with potassium sparing supplements and ACE inhibitors. Metabolic acidosis is a complication which is seen in the late stages of CKD, and gout is also a commonly seen complication. Renal anemia is usually treated with the help of nephrologists by initiating erythropoietin. It is essential to make sure that these patients are iron replete, and if they require iron, it usually is an IV iron supplementation. Do not forget to rule out GI causes of blood loss and anemia in patients who've got iron deficiency anemia. CKD related bone disease is quite common, and this is due to the fact that kidneys are required for hydroxylation of vitamin D, and therefore this results in failure of hydroxylation of vitamin D, causing secondary hyperparathyroidism. This in turn leads to faulty bone remodeling and low bone mineral density, leading to fractures. Therefore, it's important to check the PTH levels and vitamin D levels, and if vitamin D is low, vitamin D supplementation is indicated. Often we prescribe ergo and cholecalciferol with calcium or bisphosphonate supplements to prevent the CKD related bone disease. In stage 4 and 5 CKD, we require to prescribe patients with alpha calcidol to prevent complications of this bone disease. And finally, monitor patients who are on alpha calcidol with phosphate and calcium. Hyperkalemia, which is often a common complications seen again in the later stages of CKD is easily dealt by discontinuing potassium sparing diuretics, eliminating NSAIDs if they are taking any, and also counseling patients to avoid high potassium containing foods. If the hyperkalemia still persists, it is then necessary to discontinue ACE inhibitors and ARB. But most patients who've got stable, mild hyperkalemia, it's not an indication to stop the ACE inhibition treatment. Remember that certain foods may have very high potassium content, such as granny or seeded bread, cherries, grapefruits, tomatoes, bananas, beetroot, and the list is not exhaustible. Gout, which is a frequently occurring complication, is seen in CKD, can be easily managed with reduced dose of colchicine, which is preferred over NSAIDs or steroids. Frequently occurring attacks of gout require management with long-term treatment with allopurinol. However, asymptomatic hyperuricemia is not an indication for long-term treatment. Metabolic acidosis is managed with giving patients sodium bicarbonate supplements and maintaining their bicarb level less than 20, and this often is seen in the later stages of CKD. The imaging of choice in CKD is ultrasound, and this is to confirm the presence of two kidneys. It also can identify the size of the kidneys, and if the patient has small kidneys, it may be an indication of chronicity or presence of renal artery stenosis. Nephromegaly or large kidneys is a feature of adult polycystic kidney disease or diabetic kidney disease. We can also find out if the patient has got outflow tract obstruction and hydronephrosis or hydroureter, which would require prompt referral to urologist to relieve the outflow tract obstruction. Finally, we need to know which are the patients who would require a referral to nephrologist. Essentially, most of the patients of CKD can be safely managed in the primary care. However, if the cause of CKD is unclear, one should consider referral to nephrologist, or if the patient is very young. If the patient has shown a rapid progression of drop in eGFR, particularly greater than 25% of baseline within 1 year, then this should warrant a referral to a renal physician for investigations. And managing complications such as renal anemia, we would require the patients to be referred to a nephrologist. Those patients who have suspected renal artery stenosis should be referred to nephrologists. And finally, those patients who've got hypertension which is not very well controlled with 4 or more agents should be referred to a nephrologist. I hope you found this short video useful, and we'll be back with further videos in future. Thank you for watching.